Here we got wrongs part 4 from June 26th. This is going to be the longest one. So the first one that they have is a peritonsillar abscess, and they mention that the kid is allergic to penicillin. We chose erythromycin because correctly a macrolide would be the alternative treatment if somebody needed antibiotic prophylaxis with a dental procedure, given the pretension or given the previous history of endocarditis in that patient or a prosthetic valve. But for this person, they have a peritonsillar abscess. They have an active peritonsillar abscess. They have fever, severe neck pain, trismus, localized swelling, fluctuance over the tonsil. So that person, their first line would be a beta-lactam. But because of their penicillin allergy, they're saying that clindamycin is a suitable option, which is a reasonable thing to say. It's an abscess above the diaphragm, clindamycin if you can't use a beta-lactam for somebody with a peritonsillar abscess. Next was a sort of impossible one. It's a boy with HIV whose CD4 count is above 500, and they're saying, what are they most at risk for? So they're saying that this person is at risk for toxicity over risk associated with joining the swim team, sexual activity, traveling to Africa, or working in a daycare center. It says the toxo is caused by toxicity, an intracellular protozoan parasite. It's most commonly transmitted to be the ingestion of oocyst cat feces or infected meat. They do like the meat part. They're saying that patients with HIV infection who test positive for toxic antibodies are treated empirically with sulfonamide and permethine. If cerebral toxoplasmosis is suspected, diagnosis would have to be confirmed by a brain biopsy, and then cerebral toxoplasmosis is an AIDS-defining illness. I'm not really sure what they're getting at here. I guess they're just saying that, and they're just saying avoidance of which of the following is most likely to minimize the chances of opportunistic infection. So I guess they're saying that the sexual activity, the traveling to Africa, working in a daycare center, those are not opportunistic infections. Those are just regular infections that just anybody, I guess, would get. Like they're saying, working in a daycare center puts you at risk for common cold, RSV, gastroenteritis, but none of those are opportunistic patients for patients with HIV. Interesting. Next was somebody with, most likely you were able to tell they had ovarian cancer, but instead of saying that they were just going to do an oophorectomy, they were just going to take the ovary out. They wanted to phrase it operative exploration, which doesn't really make any sense because if you know that there's a mass in there, you're going to have to take it out. I don't know what they think the other option here is. You're just going to open it up and look at it and be like, oh, no, there wasn't a mass in there. Like you already had a pelvic ultrasound that showed an 8x6 complex multiseptite right ovarian mass with no ascites. Most likely was ovarian cancer, but you're not going to know if you don't take the ovary out. So I'm not really sure what you were supposed to get out of that, but testing for BRCA mutation was definitely not what they wanted. Fun thing, apparently they don't like microgram, like the UG. They want to see milligram MG. And then if you're gonna do a 0.125, they would rather you write 0.215. They like leading zeros, they hate trailing zeros. Next was a multiple myeloma question that you just read over too fast. They have high creatinine and lower back pain. Let's see. So we went with MRI of the spine because maybe why not prostate cancer? Let's see if they give a halfway decent answer for why not. They say that MRI of the spine could help identify lesions associated with multiple myeloma, but would not confirm it. So they're basically saying that you shouldn't have even been thinking about prostate metastases. And I got to tell you, I disagree with that. I don't understand why it's unreasonable to think that they had prostate cancer here, but They've got poor creatinine and lower back pain in a 68-year-old dude with weight loss. Again, I mean these are overlapping things with prostate cancer. They have a smoking history, um, not necessarily linked heavily to either of them. Um, so, anyways, yeah, you're going to do an SPEP UPEP on that person, and you would only be able to confirm it with bone marrow biopsy, which is going to show uh, preponderance of plasma cells. Next is getting the patient thiamine. So I think we've gotten this wrong just about every single possible way. There was one earlier that they wanted to give them lorazepam, and we gave them thiamine, and then this time we gave them thiamine, and they want lorazepam. So just when they want thiamine, they need to have things like encephalopathy, ataxia, and oculomotor dysfunction. Um, the oculomotor dysfunction, especially, I feel like the palsies that they get or the eye movements that they get tend not to be the thing that they show, tend not to be the thing they get when they're having the withdrawal and they need the benzodiazepine, especially the lateral gaze palsy. But really, the lateral gaze palsy, ataxia, and amnesia are all more like Wernicke's type of thing. And for that, they want thiamine. Next is going to be a 14-month-old girl with asthma. These are just tough because you're not getting a great history. Saying they have a 3-week history of a cough, and the dad described it as a dry smoker's cough. She had bronchiolitis in the past. She had eczema. She has eczema, which I think was supposed to be some big Q in. The growth chart, we're at 20th percentile for length and then 10th for weight. And that felt like cystic fibrosis to me. But then when you get into it later, they're like, oh no, clearly cystic fibrosis would have been diagnosed by now, or there would have been a family history. And that's just nonsense because, as we've seen plenty of times in the past, MBME has people get diagnosed with cystic fibrosis all over age groups and plus or minus a family history. Sure, that's classically what there would be. And really, even in this instance, they're saying the mom has asthma and the dad has seasonal allergies. So I've had questions in the past where they've had you infer that was like minor CF. But in this particular instance, they are looking for asthma in the 14-month-old. It has an isolated cough in the absence of wheezing or shortness of breath. Diagnosis could be made with methacholine challenge, or you can check and see what the response is to a bronchodilator test. And/or. Next is a patient that has diabetic nephropathy. They have stage 4 chronic kidney disease, and they want you to do the arrows for phosphorus, calcium, and calcitriol. We went with increased on everything, but in this person with stage 4 chronic kidney disease secondary to their diabetes, they're going to say that the phosphorus goes up, the calcium goes down, the calcitriol goes down. I'm pretty sure that their line of thinking there is that the 1-alpha hydroxylase activity of the kidney goes down. So you can't get the calcium the way you normally would. You can't make the calcitriol the way you normally would. And that the phosphorus is just going to keep going up because the kidneys are not excreting it the way they normally would. Here we have a 7-year-old boy who came in for an initial well child, and they want to know what's going to be an abnormal value in their lab studies, and it ends up being serum calcium concentration. How the heck did they get there? Well, they're telling you that the kid has narrow palpable fissures, low set ears, broad nasal bridge, micrognathia, downward turned mouth, and small teeth. He was born with a cleft palate and a heart defect. Those were the big ones. So a whole bunch of midline things. You're supposed to say he's got DeGeorge. You're supposed to say that he has thymic parathyroid dysplasia, and he's not going to have the right calcium. That's the line of thinking that you have to have there. What's going to happen in a 12-year-old who has a 2-hour history of severe weakness involving the right side of her face? Well, she's just going to get better on her own. This is always a safe guess. But in this particular instance, I thought, well, maybe she's got like a arteriovenous malformation. No, not that exciting. 2-hour history of severe weakness involving the right side of her face. Weakness had been present since the time she woke up. She was drooling from the right side of her mouth, and she had an upper respiratory almost 3 days ago. At this point, she's got pain in her right ear. Her speech is dysarthric, and the right side of her face, the entire face is severely weakened. And she has an inability to sustain eye closure against resistance. So they're saying that she has Bell's palsy, which could be a viral mediated inflammation, possibly idiopathic. Usually gets peaked around 3 weeks after onset, and then will get better by 6 months later. You can get steroids like prednisone as well as antiviral antiviral only if it's a severe case. Next was somebody who was anemic. Just keep in mind that for this person, they're telling you that they're anemic, and the only thing they're giving you is that the hematocrit is low. They couldn't be bothered to give you a hemoglobin here. Then they start giving you some weird kidney findings, like there's 2 plus glucose, 1 plus protein. But what they really wanted you to say is what would have prevented his hematologic condition. His hematologic condition is iron deficiency anemia. And they're saying that in a 62-year-old, one of the most common ways that he's going to do that is right out the butt. And so he needed colorectal cancer screening. GI blood loss is a very common cause of chronic iron deficiency in an older patient. Next was you trying to be a genius, and you're thinking, oh, well, this pH came back, it's acidotic. The bicarb is showing acidotic, but all of his findings are asthma related. So maybe he just has good old pure respiratory acidosis with an appropriate compensation. But if you actually did the whole Winters formula, it would actually show you that having a 20 bicarb was not an appropriate compensation. And so in reality, he actually has a mixed, I love it when they do this, mixed respiratory and metabolic acidosis. Both the respiratory and metabolic are both acidotic because it's not enough of an actual compensation for what was going on with the asthma. Next was green stuff coming out of the nipple. They're basically saying that you're supposed to just know that ductal ectasia is when things come out of the nipple, even in a 16-year-old. And it's green, it's not blood. That's fine. That's what they want. They're just saying that she most likely has mammary ductal ectasia in a 16-year-old. Mammary ductal ectasia is a widening of the lactiferous ducts near the nipple. It's associated with inflammation and consequent nodular or cystic formation. Ductal ectasia may be asymptomatic or painful, and it might even be multicolored, but a sticky nipple discharge is pathognomonic for mammary ductal ectasia. You can get a complication like a breast abscess. Treatment is usually just symptomatic. You would only do surgery if they did not respond to the symptomatic treatment. Now we have the other one. This is the other one. So this time we gave them B1, and they wanted to give them the lorazepam this time. They're saying that he has a tremor on his hands and that he had been drinking a gallon of Scotch whiskey for 3 years. So he's saying that he is seeing cockroaches on the hospital bed. So now he has delirium tremens and he needs lorazepam. This was like complete non sequitur when it comes to NBME material, but they give you a image of baby's head. They're telling you it's a CT scan, even though all you see is just bone. So I've never seen a CT scan like this before. And they're saying that the patient has coronal craniosynostosis, which really what you had to lock onto was that the right eye and eyebrow were appearing superior displaced compared to the left. So there was this head asymmetry. And apparently, if you're really smart, you would know that the sutures on this 4-month-old baby's head were all closed. And so then what it really was coronal craniosynostosis, causing this asymmetry of the face. Next was a patient who had only symptoms related to them gambling. but they still wanted bipolar disorder. They only come up with these energy spurts when it comes to gambling, and then they don't need to sleep, and they don't realize what they've done until a week later. This sounds a lot like pathologic gambling to me. They're not giving you any information of this happening in any other instance. But for this person, they're still going to say that it's bipolar disorder. Now, they're saying that pathologic gambling is characterized by escalating gambling habits, which is funny because this is exactly what happened with this person. This was the most they had ever lost before. They're saying that unsuccessful attempts to quit gambling. It never says that she tried to attempt to quit. Persistent thoughts about gambling, attempts to make up for lost money, functional problems as a result of gambling, and other gambling-related issues. This is blurring the lines just to blur the lines. Okay. You really could have gone one way or the other. You can't get mad about missing this one because this is just teetering. It really is. Just nitpicky. Asymptomatic exposed to gonorrhea. They're saying just give them the ceftriaxone and the doxycycline anyways. They are often asymptomatic, and if you leave it untreated, it can cause disseminated disease. That's fine. It's a dude who bangs other dudes. So it just seemed like somebody's going to get symptomatic out of this. But they're basically saying just wait until the gram stain and the urethral swab come back before you stop doing the empiric treatment of both ceftriaxone and azithromycin or doxycycline. So you got to concurrently treat for the potential Neisseria or chlamydia in this patient, despite the fact that they have no symptoms and their gram stain from the mucus from the urethral swab has already come back as negative. So all you're waiting on is a urethral culture, and you're still supposed to just give them antibiotics because their partner, their exposed partner, has it. Next was them just writing the same exact question that they've written before. And before they wrote it and they said that they had hemophilia A. And then this time they wrote the same question, except for instead of making the PTT high, they made the PT high this time. So if the PT is high, then it can't be factor 8. It can't be hemophilia A. It's got to be just factor 7 deficiency, which is a rare bleeding disorder caused by, you guessed it, a deficiency in clotting factor 7. Okay, that's all they've done here. They just wrote you the same question. They said 3-year history of bruising without any trauma, no bleeding from nose or mouth. They're trying to tell you no platelet issues, basically. They're showing you the exam has numerous ecchymoses, various stages of healing over the upper extremities. And then the PTT ends up being normal, and the PT is high. Okay. So in the future, we're just going to have to remember that our hemophilia people and our von Willebrand people are indoors playing table tennis. Next was a lady with tinnitus. Maybe I've seen this somewhere before. Certainly from the stupid movie Baby Driver. He had tinnitus, and there just wasn't anything to do about it. For her, it just says like she's got ringing in a quiet environment. But then the exam of the auditory canal shows no abnormalities, and finger rub testing shows no abnormalities. It does tell you that there's mild high frequency hearing loss bilaterally, but apparently if it's because of the tinnitus, then you just don't do anything for it. Tinnitus is internally generalized sound, most commonly related to sensory neural hearing loss, but it could be idiopathic. Audiometry is commonly used in patients with tinnitus to assess for associated hearing loss. In patients with symmetric and non-pulsatile tinnitus, no further testing is indicated. Management would include stress reduction, cognitive therapy, as well as masking the external sounds to distract from the internal sound. So just like the movie, it's got the music in his ear. Okay, here we have a weird rash, anaphylaxis type 1 type of thing that happened. And it said, what could have been done to prevent the patient's current condition after having an IV line placed? And you're supposed to know that it was latex gloves that caused this. They're just saying that anaphylaxis is IgA mediated. Of course it is. Extensive degranulation of mast cells and basophils. Of course they are. Has bronchospasm, dyspnea, wheezing, urticaria. Not disagreeing with any of these things. Treatment begins with epi. Then you can give antihistamine, bronchodilator, glucocorticoids. Again, all things that are perfectly fine. Avoidance of latex products is recommended in the care of patients with spina bifida, as well as those with allergies to banana or avocado. Those 3 different people are associated with high incidence of latex allergy. And they had told you as a newborn, this patient had surgical repair of myelomeningocele and creation of a VP shim. So they're at higher risk for a latex allergy. Last one was peptic ulcer disease. We knew that it was H. pylori, and they were saying, well, we're going to give you the PPI, and then we're going to say what other 2 drugs. So you had to do a triple drug. You had to do a triple drug therapy with one of the drugs being a PPI. And so all you really knew was that it definitely wasn't the ones that had bismuth subsalicylate, because that's the quad therapy. You picked amoxicillin and metronidazole. That was half right. They did want amoxicillin, but they wanted amoxicillin with clarithromycin. So they wanted a macrolide with amoxicillin along with the PPI for the triple therapy. So MAC, MOX, PPI, MAC, MOX, PPI.